Hi, everyone. Welcome to the final episode of this crosscast RhAPP, MAPP, GHAPP, and SDPA series that we've engaged on. This is our fourth and final conversation where we'll talk about the conversation that matters, how to talk to your patients about obesity and IMIDs. My name is Amber Blair, and I'm here as a dermatology PA, a representative of SDPA and DermCast. And I'm surrounded by three amazing colleagues that I'd love for you to introduce yourselves and share who you're representing today.
Hi, everyone. My name is Jennifer Jeremy. I'm a physician assistant in Gastroenterology at Brigham and Women's Hospital in Boston, and I'm really excited to be here with multiple disciplines that are treating our IMID patients.
Hi, my name is Naomi Amudala. I'm a nurse practitioner, and I work in rheumatology at Penn Medicine in Philadelphia.
My name's Jennifer Mackey. I work at the Cleveland Clinic Bariatric and Metabolic Institute. I'm representing MAPP, and I'm here to talk about obesity medicine.
In the beginning parts of this series, we really addressed more of the epidemiology, more of the pathophysiology, the mechanistics behind obesity, and the interactions with immune-mediated inflammatory diseases. Today, we're changing strategies. Today, we're talking about how to enter a room with a patient, somebody's mother, brother, father, sister, or daughter, and really have a conversation with them about obesity in a way that's sensitive, in a way that's practical, in a way that's well received and heard. How can we make a difference in these patients' lives? And hopefully by the time we're done here, we'll have some specific strategies that you too can implement in your practice on a daily basis. Let's start with the big burning question. Start with why. Why is it so important that we're having these conversations with these patients in the clinic in the 10 or 15 minutes that you have to do so? What's the why?
I think the whole person, right? We need to look holistically at the patient and look at the fact that their weight status, their obesity is contributing to their inflammatory cascade. And so we want to improve their outcomes with whatever therapies that we're using for those conditions. And so looking at the holistic approach, we also want to then look at how we can mitigate their contributing factors with obesity is how I perceive this.
This is one of those areas that many clinicians walk into the room really worried about damaging their rapport with patients. How do you address that, or how do you keep that in mind while still getting the goal across of having these conversations?
Yeah, I think it's tough. And I think no matter what we say, there's stigmas around weight and people are sensitive about it. I think that you need to have a trusting relationship with the patient. You don't want to just come up to somebody you've met for the first time and start talking about their BMI. You want them to know that you have their best interests at heart. So maybe that's a conversation you have the second or third time. And I also think timing is key. So if I'm seeing a patient with psoriatic arthritis and they're having a really bad flare with their joints all swollen and a bad psoriasis flare, that's not the time to talk about the BMI. So maybe that's when, after the flare has subsided and they're doing a little bit better, let's talk about management strategies to prevent additional flares.
It's so important because we know what can happen if we don't address it, but we want to address it in a way that it can be well received and it's not the last time we see the patient, right? And understanding, back to the pathophysiology, why the inflammation is there, what is happening, and what's driving the disease process, trying to get the patients on the same page in an empathetic, kind way really helps them achieve their goals quicker. Mm-hmm. What language, when you're having these conversations, are you using? How are you framing this conversation with the patient? Do you have any tips for somebody who's new at implementing these conversations?
I could speak from the rheumatology standpoint. So when I do mention obesity to patients, I like to first of all, do it in a very non-judgmental and kind of clinical way. So this is where we are talking about whatever we can do to make you feel better. We know that there are certain lifestyle modifications that you can make that will decrease inflammation. That includes stopping tobacco use, reducing alcohol, and getting your BMI down. So putting that all together and just taking away the stigma, I think that helps.
And I think it's important, too, to have small, measurable goals. Like, what little thing can we do that you can manage to make a difference? And then when somebody realizes they can do that, then they know that they can do something else. And just trying to slowly roll out versus you need to change literally everything that you're doing right now and do all of this instead. That doesn't work.
That's so overwhelming.
Yes. It overwhelms me just thinking about it. How can motivational interviewing techniques be used to better engage patients who are struggling with obesity and concomitant inflammatory diseases?
The motivational interviewing techniques that we should use is starting with the patient. You want to ask the patient what's important to them. What are they trying to achieve? When a patient walks into my office, I can't assume that it's weight loss solely that they're interested in having. What if they come in and they say something totally different than what I'm expecting? Maybe they want a better joint pain, less fatigue. What if they want totally different goals? What if they just want to walk 500 feet, 100 feet? Maybe they're not coming in to see me just for medications. I need to listen to them and understand exactly how I can help them. And to my surprise, patients do come in and they don't necessarily, not everybody's coming into my office asking for GLP-1s. There are a lot of patients that do, but it's also important to ask that question as well. If they do say medications, I say, tell me what you know about medications. What medications do you know? What medications do you want to try? What medications have you tried in the past that maybe you've tried and failed, or do you want to try those again? And then some people will come straight out and say, I don't want to take a shot, or I don't want to take a medication that's going to cause a heart attack, or, they have misconceptions about medications as well with phentermine, with the increased heart rate and tachycardia. So just, finding out what they want and kind of catering the plan of care to what they want.
Absolutely. And that just plays right into this shared decision making that we have with the patients. And we kind of loosely show these are our offerings that we have. What are you wanting to get out of this, and where can we meet in between? And you bring a good point up talking about side effects. Sometimes patients will come into my clinic and say, I don't want any of those biologics. I know all about them. So then I'll change my dialogue a little bit. Speak to me specifically about what side effect you're concerned with, because a lot of it is misinformation. And if I can take some of that off the table along in our trusting relationship, sometimes they're open to something that really is in their best interest, and they weren't originally because they were scared about something that wasn't really something that existed.
Right.
We have learned a lot and heard a lot about the stigma associated with obesity and these patients that are also inflicted with immune-mediated inflammatory conditions. And this stigma around obesity, it's not new. It's been going on for a long time. And it's really hard to kind of get past it for some patients. And sometimes as healthcare professionals, we're not doing it any justice. So how can we do better from a stigma standpoint for these patients?
There's so many ways that healthcare providers can do better. We have to acknowledge our own personal biases against patients with obesity first. So instead of coming in and writing your note, I have a 30-year-old obese patient, we need to change that narrative. We need to talk about the patient with obesity, diagnosing a patient with class 3 obesity versus morbid obesity. Nobody wants to be called morbid. That sounds terrible. And it's not accurate. It's going to cause patients not to come back. If you think they're morbid, why are they going to listen to you? Why are they going to follow through with the treatment plans that you've prescribed? So I think it's really important that you engage with the patient. You talk to them more about them as a whole person versus their disease that they came in to see you for. They aren't obesity. They aren't the picture of arthritis. They are not arthritis. They are not obesity. They're not their disease. But talking to them more in a holistic way and letting them know that you're there to take care of them as a whole picture versus just one disease is going to be very helpful. And they'll listen to you.
It's interesting you say that. I've had recently the opportunity to go to Capitol Hill and talk to some of our legislators about issues that are pressing on the Hill. And before they just send you out there, they coach you on what to say and how to say it a little bit. And that's the first thing they say. You have to tell your story and don't talk about obese patients. Talk about patients that are suffering with or struggling with obesity. Make the patient the center, not the disease the center. And that way it personalizes a situation versus just another patient going through your day. So important.
It's so important to talk to people like people. These are real life people that we're treating, that we're taking care of, and that one thing does not define who they are. It's not fair. And as healthcare professionals, it starts with us.
I also think trying to pivot and not put blame on the patient as making poor food choices or lack of self-control. No one chooses to be in that position, and we are not blaming you for being in that position, I think is also important.
Educating yourself that it's not calories in, calories out. If you exercise more, you'd lose weight. Look what happens when you follow a diet. You lost weight. But that's not exactly how it works. So educating yourself as healthcare professionals on what obesity really is.
And that's really what brought all of us here today and all of the participants in conferences like this. It's the need for knowledge and trying to be a better healthcare provider. How can we do better for our patients? At the end of the day, that's what we're here for. So now, as we're taking all of this knowledge that we've gotten and we're able to disseminate out to our audiences, again, one thing for the newer APPs that are really trying to incorporate these conversations, or now learning that they should be trying to incorporate these conversations of obesity into their conversations with the patients, what's one thing that they can tangibly do starting on Monday that can make a difference in these patients' lives?
I think once you've opened that door to have the conversation and the patient has welcomed the conversation of addressing weight management, we're not explicitly sending them all to a bariatric surgeon and prescribing, injections. Small incremental goals, one, that the patient can achieve, that is realistic, and two, that you're comfortable in starting that conversation, and then it's a build, right, to any potential subsequent intervention. So maybe that can be, I do no physical activity outside of my activities of daily life. And some activities better than no activity, that's intentional. And that can be something small like a YouTube stretch video a couple times a week, a walk around the block. That is, again, not the gym, not, Ironman style workouts. That's tangible for the patient. If we've reviewed their dietary intake and their patterns, making a swap out of a particular maybe snack food, or incorporating a meal that they often skip, or potentially reducing a certain thing that they consume, not eliminating, right? Because that's not realistic or tangible in the small. So a small incremental goal, and even if when they come back to you, their weight number has not changed, rewarding the, hey, I'm glad to hear that you've been taking that walk a couple times a week. Do you think maybe we can increase that by 10 minutes? Or, I'm glad, whatever that goal was that the two of you decided on, and if they didn't make that, well, why? How can we then repivot? So it is not all and everything in the toolbox on day one.
Okay, that concludes our fourth and final episode of this podcast series. I just want to say a heartfelt thank you to you all for joining us today, for all working together for what's in the best interest of this patients, trying to help people understand that immune-mediated inflammatory disease and obesity is truly interconnected. And how can we have these conversations with patients, and how can we make a difference? We hope that this conversation has left everybody feeling empowered, that they have all of the knowledge that they need to really begin having these conversations within your clinic. It's been fun for us to do. It's been fun to learn about here. We hope we've given you some really actionable guidance to take back to your clinic on Monday morning. And if you happen to not be a member of your professional society, now's a great time to join GHAPP, RhAPP, MAPP, SDPA. Incorporate that into what you're doing. And maybe you're a member of SDPA, but maybe you should be going to a RhAPP conference. We can get an incredible amount of additional insights by looking at this through the viewpoint of a different specialty. But it doesn't stop here. Continue your education, continue to learn about this. I think the research is coming. We're going to learn more and more about how these diseases are interrelated as time goes on. So stay in tune, join your conferences and your congresses, and thanks for listening.
That's a wrap.